Just joking. Okay. Okay. All right. Good afternoon, everyone. We're running a few minutes behind, so I think we'll continue to get more people and more interest as well. But without further ado, thank you very much for joining us for thematic session 6B. That's digital innovations across food and health systems. My name is Julie Gosla, and I work at the International Food Policy Research Institute. And it's my pleasure to introduce our session chairs. Our first is Mevan Pires, who's the CEO of Hatch, an organization supporting a network of over 700 startups through co-working spaces, incubator accelerator programs, and investment advisory. Hatch is also present in Singapore and the UAE. Mevan sits on the Ceylon Chamber of Commerce's Steering Committee for Entrepreneurship and SMEs and consults businesses on strategy, operations, and marketing. Previously, he held senior roles in hospitality, FMCG, and technology sectors, including heading operations for Pick Me Food and marketing for Elephant House Beverages. Mevan was listed in Forbes 30 Under 30 Asia for 2020, a Chevening Scholar with a postgrad in Innovation and Entrepreneurship from the University of Warwick. He has been involved with the World Economic Forum's Global Shapers community as well. Next up is Ben Weissman, who's presently the CGIAR Nutrition, Health, and Food Security Impact Platform Manager and a project manager in World Fish. He has been engaged in various capacities, including as a co-author and reviewer for various papers and publications, including the UN Nutrition Discussion Paper on the role of aquatic foods for sustainable healthy diets. He has also played key roles in developing the World Fish 2030 Research and Innovation Strategy and implementing the CGIAR initiative on Asian megadeltas. He holds an honors degree in zoology and psychology from Science University of Malaysia, Penang. Please join me in welcoming them.
Thank you very much, Julie, for the kind introductions, and welcome everyone to the 6B session, Digital Innovations Across Food and Health Systems. So as Julie mentioned, we are still anticipating people to trickle in after lunch, but we will get moving. It's been a pleasure to be back here, and I'd just like to frame a little bit of what we're going to see today. So we all know that the revolution towards digital innovations are inevitable, right? We need to move with times, and in fact, what happened is that we saw during the COVID-19 pandemic, a lot of systems had to move towards digital innovation. Cash has now become e-wallets, etc. So how then do we make sure that this digital innovation and digital revolution doesn't displace people? And how does it move so that the vulnerable, like women, like youth, like many of us here in the room, are not left behind? Now, it's a pleasure for me to co-chair this session with Mevan. And to kickstart things, I think I'd like to invite the first speaker, Pawan Kumar Patil. He's from the Action Against Hunger, and he will deliver on an innovative digital application, MAAP. Pawan Kumar, the session is yours.
Good afternoon, everyone. It's my pleasure to be here, and I love this conference a lot. You might have noticed it already, because it brings these unique opportunities for all of us to come together, try to understand each other's perspective on solving these common problems by building on our unique opportunities and unique qualities. So today I'm going to present an innovative digital application map that we co-developed in this last 1 year, looking at the problems that we have identified in the field while working with Action Against Hunger India in 4 states of India. So I'm representing a large group of co-authors and people who are involved in making MAP possible. We have Samath and Dheeraj here from DSDC, but we have so many other co-authors attending the session from India online. Including Isha, Akshay, Shambhavi, Garima, Vinay, so on and so forth. So thank you, and I'll get going with the session. So Action Against Hunger works in 4 states of India, Maharashtra, Madhya Pradesh, Rajasthan, and Gujarat. And why do we work here? Because India hosts half of the world's wasting and almost 1/3 of world's stunting. And as many organizations can come together, still this problem will look a huge challenge to solve, and we try our own ways to deal with this problem. We work from community-based management of acute malnutrition, food security, livelihood approaches, 1,000 days, various digital solutions, in detection and treatment of malnutrition. In this process, we use technology heavily. We use the technology to empower our frontline workers, government frontline workers, collect data, analyze data, visualize, and then use these data points to shape our policy. During this journey, we also realized that so many applications and tools that currently being used are from the service provider's perspective. So either they are used by the NGO workers or they are used by the government workers. Early identification is very critical, but it's again a very mammoth task, looking at the huge population in these geographies and the limited workforce, limited resources for NGOs, makes it little difficult to be on track of routine screening of the children. We know that communities now, they have shifted from being just the recipient of the technology to the active users of the technology. They use WhatsApp, Facebook, Instagram, Reels, very effectively. But as I said, that current digital solutions that we see, most of them, they do not look at the community as the users of the technology. They use the technology for getting the information from the community and giving them the information. So we thought that there is a huge gap that we can look at. Why the community needs to be just the passive recipient of the technology, and why can't they contribute through whatever little way into this entire puzzle of solving malnutrition. So with that idea, we thought that let's look at solution from the community's perspective. We had various fancy ideas when we started the exploration, but we also realized that we should look at what is bare minimum that we can do, and we should not be we should not get hyper excited about this process. Can we empower the caregivers to proactively detect or at least sense malnutrition in their child? Can we empower them to reach out to the NGO workers or the government workers instead of this always happening other way around? And take proactive action if we see that this particular child could be potentially malnourished, instead of waiting for the 3 months or 4 months of screening cycle, that can happen much more frequently. So we use MAP as a digital tool for proactive nutrition action. We did not have funds for this particular initiative. It was an idea. So we were looking for people who would help us with, the idea is really good, but then who would get it implemented. So as I said, that it was very clear that we had to enhance the early identification, improve the timeliness of the intervention, promote self-efficacy, reduce relapse, and inform the system for improved programming. So the app needed to be developed. But then we also thought that current channels in the communities are, there is this mother and child, the NGO worker and the government worker, they look at them as beneficiaries. And MAP can potentially solve this thing by changing the direction of the information and making it a continuous recharging system of information and action. So what we realize is if this is possible, then this system also can help the strengthening of the system. It will help proactive care seeking. It will also make the community as a decision maker into what is happening to their child, whether something is wrong, and being very aware about the subsequent steps that are getting taken place, policy updates, platform integration, capacity building of them and of the community, and eventually shifting the way interventions are delivered in the community. But then again, we cannot look at it from our pinhole of the world view. We need to look at the community's worldview, how they look at the technology. we ask not only the community, but also the NGO workers and the government workers, what are the exact challenges they face in detecting malnutrition, anthropometric assessment, and closing this loop of malnutrition quickly. We wanted to understand from them, we wanted to get their insight, we wanted them to actually co-design the solution with us. But then there were various challenges. The way we perceive it, they might not pursue the knowledge and information in the similar manner. So just the way we look at red as a negative thing, for them, red color in the MUAC is a positive sign, an auspicious sign. So how do we build on this new knowledge? What is the preferred communication channel? So based on these learnings, we designed this application. It went through a lot of design thinking principles, co-designing, and ultimately, I'll just quickly show you that where are we at. So this is just one of the features of the app where the mother is looking at the child. She is enrolling. The entire platform is guided by audio-visual cues. So she doesn't need to read or write. And she can get help if she thinks that her child is being prompted as potentially Sam, potentially ma'am. And then she has the videos for taking proactive actions at her home, but also reaching out to the right support system in the existing support system. Where are we at? We are piloting this application in urban slums of Mumbai, where we are trying to see whether we are adding any new burden to the family, just because it is our intellectual itch that the digital solution needs to be incorporated. And we think that this exploration will guide us whether we are on the right track. Thank you so much.
Thank you very much. Next up, I'd like to invite our next speaker to speak about AI and blockchain-embedded energy access for e-cooking and post-harvest management. I'd like to warmly welcome Manojit Ray, visiting research fellow from the University of Toronto.
Very good afternoon. In the short presentation, we are going to look at the impact of digital innovation-enabled energy system on agri-food system, agri-food and food security. So first, where are we? As we speak here, in last 3 days of this conference, we have lost around 40,000 under 5 kids around the world. Most of them are in South Asia and Africa, to unhealthy indoor air pollution induced respiratory infection. Main cause is that the women and who are mainly the cooks in the kitchen, these kitchens are closed kitchens, and they use polluting fuels. So what we can do is to save these children and their moms from this horrible situation, if we can provide electric cooking. But unfortunately, many of these places, they don't have access to clean and affordable energy. Another major problem is that we know around 1/7 of the entire food that is produced and grown around the world that gets wasted simply because we don't have enough cold storages and cold chains close to the places of production. And these cold chains are highly energy guzzling facilities that require resilient energy at an affordable price. Unfortunately, resilience is simply not present in those places, most of these places, and that makes the investor to invest in resilience-inducing DG sets and such things. That makes the energy unaffordable, and in turn making the entire cold store unviable economically. That's why we simply don't see them there. And that's how we end up losing around 1/7 of all the food that we produce. So do we find, like we started this journey on this research about almost close to a decade back at the University of Toronto. And when this SDG 7 came about, we didn't even have a process to measure where energy access is. So we are trying to look at what kind of digital innovations can actually aid the energy system to power these kitchens and these cold storages. It's really possible. And this morning we have heard from Gita ma'am that we consumers are very powerful. We also spend close to 15 trillion. And in this research we have seen that actually if consumers come together, we can really create situations which are simply unthinkable if we fail to come together. So will we come together and can we come together? Those are different questions. But if we come together, then what happens? So it's actually nearly magic. So there are 47 slides. I'll not be able to cover all of them. So yeah, so I'll only cover probably 4 or 5 slides. I'll leave the rest. If anybody is interested, we'll be there to discuss those things. Okay. So I'll skip this. Okay. So don't we have energy? So that central small bubble kind of stuff that says world energy consumption is 16 terawatt. So that's the entire energy consumption in an entire year in the world, and that large yellow circle is what we get from the sun. So we have so much abundance of energy is all pervading, but still we don't get access to affordable and reliable power. So why is it that? It's primarily because energy is there, but it's not there in the form that we want, where we want, and when we want. So what can we do about it? This is what SMAP of the World Bank Group did. So initially we could measure access only in 2 different levels, access and no access. It doesn't make sense. I'll again not go into details of that. Now we have 5 different tiers plus tier 0. So basically the access tier quality varies between 0 and 5 now. Okay, so 5 is a better one, and 0 means no access. The new framework, it addresses capacity, duration, reliability, and safety, and it also addresses affordability. From this affordability, we'll get something fascinating at the end of this presentation. We'll look at the world map. Our study covers 88 nations around the world, and we'll find some results. So results are somewhat counterintuitive. Okay. So apart from, we are like the title of the presentation says that we are going to look at AI and blockchain, but actually we are also going to look at demand response. What is demand response? So historically, the power system has remained a supply-driven ecosystem. So whatever the producer supplies, as consumer, we are bound to consume it if we want to. If we don't want to, then we can definitely switch it off. But the problem is the entire grid operates on demand and supply balance. If the balance moves beyond certain stipulation, the entire grid crashes. And earlier it used to happen across wide grids, like covering huge amount of geographical space. And we could find that major areas are going out without power across the world during different times because of simple this demand-supply mismatch, nothing else. Now, we have already seen that through demand response, consumers can engage, and we'll find the impact of that later. The other one is artificial intelligence. We all have heard about AI. AI is almost everywhere. But through pattern recognition, one of the major advantages that we have got is that we can actually forecast the kind of generation that we are going to have in solar plants and other renewable energy setups. So simply looking at the cloud cover and the movement, we can project that what kind of power one particular system will generate at a given time. Okay, and consumers could not engage earlier among themselves. For everything, we required the utility to be a participant. Now, this blockchain system allows us to engage ourselves among consumers. We can trade energy among ourselves without any meaningful participation from the utility. We need some regulatory clearance, but beyond that, technically nothing. So grid is becoming smarter using all these. So our research is divided into 4 different areas. So I'll just straight away go into the results of these, otherwise we'll not have time. So the first one is grid age. We assume that if there is a grid, then the access level will be very high, everything will be very good, but we'll find it's not the case later. Then there is another one which is off-grid, where we mostly find solar home systems, and they are mostly very weak. So they cannot power high-power requiring gadgets. But we'll find that through this demand response, we can actually use solar home systems and still power high-power guzzling gadgets, whatever that is. At times, it is even agro-machinery, milling machines and things like that. So then there is something, this is about charter. So charter is about the financial structure that drives the transaction between the supplier and the consumer. And the last one is motivation. So can we really profile one particular consumer? Is it really possible to know whether a consumer will participate in demand response or not? 30 seconds, oh, all right. So I'll go to the results. Yeah, so this is the typical supply that we get from grid age. This is from Indian Himalaya. And this is around 1.92, that's the access tier. We are expecting 5. So with all these innovations, it can actually go up close to 4. Okay, now I have to go through that. Yeah, that's what. Then in case of isolated systems, the total spending can be half of what it was original, and still we can supply everything. And the final one is, in off-grid systems, we find that 186 million people can additionally be covered by affordable energy access across all these countries. Most of them are in Africa and South Asia. And this essentially means now we can start looking at having distributed cold storages and also e-cooking. So you don't have to lose our precious children to this menace. Thank you so very much for your attention.
Thank you so much, Mahajit. Well, we're moving on to the next presentation. And again, a gentle reminder to all presenters, you only have 8 minutes. So when you're at your last 30 seconds, please try to summarize, right? Now, I'd like to invite Khadija Vatsaria. She's a doctoral candidate from Aga Khan University, and she will talk to us about efficacy of a personalized mobile health application in improving micronutrient supplement use among pregnant women in Karachi. Khadija, over to you.
Good afternoon, everyone. My name is Khadija, and I'm from Aga Khan University, Pakistan. Today, I'm going to present one of the objectives of my doctoral research, in which we assess the efficacy of a mobile health intervention in improving micronutrient supplement use among pregnant women. So I'll briefly take you through the background and rationale of conducting this study. In Pakistan, we know that women of reproductive age are facing triple burden of malnutrition, and even then, the minimum dietary diversity requirements are fulfilled by only a quarter of women. And if we see the women of reproductive age as well as the pregnant women, there are micronutrient deficiencies. And despite of these deficiencies, the micronutrient consumption remains suboptimal during pregnancy. So the antenatal care is the perfect opportunity where pregnant women could be counseled upon regarding the behaviors that they need to follow during their pregnancy in order to have optimal outcomes. So it is a widely used strategy. However, if we see the routine practices involve the face-to-face counseling. The counseling is according to the pregnancy stage and depending upon the trimester in which the woman is. And it is time-bound, given the high volume of women the obstetrician has to see. And even the compliance is not always assessed in the subsequent follow-ups. So various studies have reported that women report in the developing countries that the communication they go through during these consultations are sometimes insufficient in quality, and the amount of information provided is also insufficient. So this provided us the opportunity to test how the digital health innovation could act in this situation. So the mobile health interventions are basically delivered through the mobile communication devices, which operates through wireless technology or Bluetooth, and it can be delivered through various devices, including mobile phones, smartphones, tablets, and a variety of media can be supported by these devices, and it has the added advantage of delivering individualized, tailored, and repeated information to the participants. So if I discuss the digital landscape in Pakistan, so we have observed over the period of time that the broadband subscribers and the cellular subscribers have tremendously increased over the time. And the smartphone ownership has also doubled. If I talk about 2016, where it was only 17%, so it has doubled to around 32% in 2019. And informal reports suggest that it has increased up to 50% now. And if I talk about 2020, there were around 2 million apps were downloaded by different segments of the population. And the urban women have advantage of owning a phone compared to the rural women. So we decided to undertake this research in which we tried to assess if the mobile health intervention can actually improve the micronutrient supplement use during pregnancy compared to the traditional face-to-face counseling. So we conducted a randomized control trial with the allocation ratio 1:1. There were 2 groups, and we followed the randomization process of getting through the block randomization size of 6. And the clinical trials unit at our university facilitated the randomization process by providing the opaque sealed envelopes for allocation concealment. And the study was carried out at the antenatal clinics of our Aachen University Hospital. There were a total of 306 pregnant women, 153 in each group. So we included those women who were in their first trimester, adults at least 18 years of age, registered for delivery because it was a follow-up study, so we wanted to continue measuring the outcome. And if they possessed a personal smartphone along with the internet connection, because our intervention was dependent on the internet connectivity as well. And they were able to read and write in Roman Urdu or English, and they consented to participate. If women had any dietary restrictions given their comorbidities or any diseases, they were excluded, and if they had language barrier, we excluded that. So there were two groups, intervention and non-intervention. So the intervention group received the mobile app, which was named at Puramid Agas. So this word is the Urdu word, which means a hopeful beginning. And the women randomized to the intervention group actually received personalized recommendations. So these recommendations were based on the history which they provided on the data collection questionnaire. So these were personalized in the sense that if they were not taking folic acid, so the recommendation particularly focused on informing them that folic acid is important and you need to take it daily. And they also received 3 push messages a week, which included short context-specific messages on the advantages of different micronutrient supplements and their effects on the pregnancy outcomes. On the other hand, the non-intervention group received standard face-to-face counseling. So the counseling was based on WHO recommendations of micronutrient supplements, and each woman were followed up at 6, 12, 18, and 24 weeks after the enrollment. So we, for the analysis, we performed the descriptive as well as inferential analysis, and we compare both the groups in relation to their baseline characteristics. Given the repeated measurements over the period of time, we performed longitudinal data analysis, taking into consideration the random effects model. We performed both unadjusted and adjusted analysis. And the supplement use score was divided as 0, 1.5, and 3 for daily, intermediate, or inadequate use. But for the inferential analysis, we combined the categories of 0 and 1.5, given the sparse data in the 1.5 category, which diminished to 0 even in the later follow-ups. And the cumulative supplement use score was calculated by summing up the score of each individual supplement. So the baseline study characteristics did not differ significantly between the two groups. They were almost statistically insignificant. So in terms of improvement in micronutrient supplement use, we found that after the intervention, the iron and vitamin D significantly increased in the intervention group. On the other hand, there was more improvement in terms of calcium use in the non-intervention group. So the overall supplement use score, which was sum of the individual supplement use score, also significantly decreased, which was the point, because the higher supplement use score indicated inadequate use. So a higher reduction was seen in the intervention group compared to the non-intervention group. This was also supported by the multivariable analysis, which showed that there were higher odds of scoring adequate in the intervention group for iron and vitamin D compared to the non-intervention group. On the other hand, the intervention group showed lower odds of scoring adequate for calcium supplement. So in conclusion, we demonstrated that the personalized health intervention can improve iron and vitamin D among pregnant women. And since the mobile health technology is being escalated in various parts of the world, including Pakistan, so it provides a convenient, affordable tool for improving pregnancy and health behaviors. In addition, the antenatal counseling should focus on adequate diet as well as micronutrient supplement use to improve the perinatal outcomes and to prevent the complications. Thank you.
Thank you, Khadija, and thank you for sticking to time as well. Well done. Next, I'd like to invite Asif Ali, PhD research scholar in the Department of Geography from the University of Burdwan. Scaling up nutritional progress in aspirational districts of India will be what Asif will be sharing today. Over to you.
So good afternoon, everyone. So this is my topic of today's conference presentation, which is to scaling up nutritional progress in aspirational districts of India, insight from a data-driven tool to ensure last mile tracking. So I look forward to sharing the key insights and discussing how data-driven approach can change the nutritional background in India. So we know that the malnutrition remains a significant public health concern in India, which starkly exacerbated by the state and the regional disparities in the India. So aligning with this, the government of India, specifically the Niti Aayog, launched the aspirational districts program in 2018. The target is to basically transformation of the 112 most backward districts across 28 states in India for improving the socio-economic indicators, promoting inclusive growth guided by the 3C framework, and importantly, the health and nutrition are giving the more focus with 30% weightage among all targeted areas. And along with that, the timely detection of the malnutrition like critical issue has long impeded the serious challenge in India. So therefore, Ministry of Women and Child Development launched Poshan Tracker in 2021, which is country's largest mobile-based nutrition surveillance system. It's basically used to track the malnutrition, like different malnutrition indicators of stunting, wasting, and underweight, and essential delivery of the nutritional services to the woman, child, and the adolescent girl in the country. So this is basically the operational cycle of the Poshan Tracker, that how data is collected in Anganwadi center and how it's disseminated in the centralized server and how finally it's available in the public dashboard. So basically, to scaling up nutritional progress, it's essential to identify the change in different malnutrition indicators and to benchmarking this progress, that how it work. So aligning with this, the present study objective to evaluate the change, real-time change, and track progress in different child malnutrition indicators across aspirational districts of India, which is supported by 3 sub-objectives. So this is basically the methodological portion. The data is basically collected from the Poshan Tracker real-time monitoring from which is available publicly from February 2023 to September 24, and additionally data from NFHS 5 extracted, which basically focuses on the children of under 5 years to provide the proper comparability with the Poshan Tracker data. And in analysis portion, we basically estimated the annualized change in aspirational districts, both in state level also, by comparing these two data set and benchmarking this change, aligning with the Poshan Abhiyan's target of 2% annual reduction in stunting and underweight And due to the lack of national target for wasting, we align the same for the wasting also. So this maps and table basically shows the state-wise distribution of the aspirational districts in India, and remarkably more than 75% of the aspirational districts belong from the EAG states of India, which termed as the Empowered Action Group states. So basically these states are characterized by the low socio-economic development, and collectively account for the half of India's total population. Now we come to the result portion of the study. So regarding stunting, the Poshan Tracker estimate 1 percentage point higher prevalence of stunting in 2024 as compared to the NFHS 5. However, the contribution of aspirational districts in India's stunting rate, Poshan Tracker estimates 1.2 percentage of less contribution as compared to NFHS 5. And there is a significant variability exists in terms of changing in the stunting prevalence across aspirational districts. And significantly, the stunting prevalence increased among 43 of the aspirational districts. And among 24 districts, the declining rate of stunting was below the Poshan Abhiyan setting target of 6%. And only 45 districts show that the target is greater than 6 percentage point. And also a respective state level difference also prevailed there, which is Madhya Pradesh, where Uttar Pradesh showing the highest prevalence of stunting, followed by Madhya Pradesh, Bihar, and Jharkhand. And regarding wasting, the Poshan Tracker basically shows the 16 percentage of less prevalence of wasting as compared to the NFHS 5. While in terms of contribution by aspirational districts in India, the percentage are remaining same both in 2021 and 2024 in Poshan Tracker. And encouragingly, the stunting prevalence decreased in 107 districts out of 112 aspirational districts in India, and the similar declining trend was prevailed over the respective state also. So regarding underweight, we saw the Posan tracker estimates a 11 percentage of less prevalence of underweight among child in India as compared to NFHS 5. And the similar trend was prevail across the all states where the significantly underweight prevalence were declined between 2021 and 24, with an exemption in Madhya Pradesh, where out of 8 aspirational districts, in 5 aspirational districts the prevalence of underweight are increased. So now we come to the implications portion of the study. So basically, not the replacement of the periodic health services in India. Posan tracker uniquely identifies the real-time snapshot of the nutritional landscape which prevailed in the aspirational districts of India, where stunting emerged as the key malnutrition indicators, also termed as the chronic undernutrition, which have lifelong consequences, are more prevalent in aspirational districts. So this real-time monitoring can be influential in focusing on the current policy interventions main targeting area, which remain distracted by this, and the future studies with combining with the periodic health survey with this current real-time monitoring can provide a more real-time framework which can provide the policymakers and nutritional stakeholders to deep insight into a more robust form of policy interventions. And last but not least, integrating a lifetime approach into this real-time monitoring. So basically, most of the life course approach into this real-time monitoring can provide a more prevalent form of policy interventions to address all these issues, so which can be helped to replacement and provide a nutritional outcomes for the large scale populations in India. So that's all from my side. Thank you.
Thank you very much, Asif. Now we move on to the only virtual presentation for the first session. So I'd like to invite Umber Suhail Khan, from a consultant with the Aga Khan University, to deliver on development and validation of an electronic application to access the dietary intake of adults in Karachi. So can we please have this person online? Thank you.
Thank you. Thank you very much. I'm audible?
Yes, we can hear you.
Okay, great. Thank you. Thank you, everyone. I'm Amber Khan. I'm from Aga Khan University. The topic of my presentation, my paper, is development and validation of electronic application to assess the dietary intake of adults in Karachi, Pakistan. So here's the outline of my presentation. Let's go into background. So approximately 58% of the mortality cause in Pakistan are attributed to non-communicable diseases. So that means that NCDs like hypertension, diabetes, CVDs, and obesity are on the rise. Women of reproductive age are also dealing with under and overnutrition at the same time. So the diet is the major risk factor of all these conditions that I have discussed here. So the importance of dietary data collection here. So the assessment of habitually dietary intake is important to understand the etiology of most of the NCDs and for managing all these chronic conditions. Dietary exposures are very difficult to measure as there is a variety of food consumed in Pakistan and every individual has their own portions and choices. So dietary assessments are essential to understand dietary habits. However, they are time consuming, resource intense because mostly the qualified person can only conduct these interviews or data collection. So in Pakistan, so far we have very limited dietary data because mostly qualified nutritionists to conduct these dietary recalls, and nutritionist analysis is a very cumbersome process. Automated tools are the solution which is being used in most of the Western countries. However, no local developed automated dietary tool is available in Pakistan, and the tools developed outside Pakistan or in the West, these two cannot be used in Pakistan because they are not culturally sensitive and the nutrient analysis will not be accurate. So what we aimed to develop our own automated 24-hour dietary recall tool that is called Foodie app for assessing the dietary intake in socially diverse adults with applicability to urban and the rural areas of Karachi, Pakistan. The second objective was to validate the Foodie app that is administered by less skilled data collectors against the conventional 24-hour dietary recall that is administered by highly skilled nutritionists. And the third objective is to assess the feasibility and end user experience in using Foodie app, focusing through focus group discussions and in-depth interviews. So the method of the first objective, so for developing the Foodie app, first we had to take the portion size estimation. For this, we conducted a mini survey and we collected the portion sizes of the population from different socioeconomic representatives. Then we could develop the food atlas, that is the food pictures. There are 3 portion sizes of each food items. We conducted the shoot with blue background and standard angles and height. So the third work was the generic recipe development that was created for all the mixed dishes and the beverages that are consumed in Pakistan, and all the ingredients were used are added in these recipes that are being commonly consumed. We collected multiple local recipes for each food mixed dish and the beverages from several different socioeconomic status households, followed by calculating the median recipe of each food item and adjusting that with 100 grams. The food composition table was also developed for our local use. Total nutrients, total energy, macronutrients including protein, fats, and carbohydrates, and micronutrients including calcium, iron, and vitamin C are added. To borrow nutrient values, we used Bangladesh food composition table and Indian food composition table, as Pakistan has none. Adjusted for nutrient retention, we did the yield factor adjustments that affects that covers the effect of cooking methods on the cooked food. So here are the features of the Foodie app. Foodie app is an interview administered application used by the data collectors with no nutrition background. So there is a standard questionnaire with multi-pass technique, which is in Urdu, and other languages can also be added in this. So there are probing questions inbuilt, and the dashboard reports total nutrient that is computed automatically of each dietary recall. So here's the feature of the Foodie app where it shows a dashboard. So the analysis comes in 2 types. First, the table shows the total meal information that we collect in the dietary recall, and the table 2 shows the total nutrient analysis of the dietary recall. So here's the difference between the Foodie app and the conventional dietary recall. As you see on the right side, the data collection is done on the tablet, as you see the picture where we add on the right side where we add the name of the food items and other information. Once the information is added in the tablet, it syncs, and then the whole nutrition analysis just appears on the dashboard. So the method 2, that is the validation of this app. So for the validation, we use the urban and the rural sites of Karachi, Pakistan. We had the sample of 360 participants, which were adults 18 to 70 years old. We used simple random sampling, and the study continued for 1 year, and then the COVID affected our study at the end. The validation of the Foodie app against conventional method, we collected the data, same day data from Foodie app and conventional method to compare the data from the both methods. 3 times a year, we collected the data 3 times a year from each participants, and the random sequence of data collection from both the methods was done. So for the third objective, we conducted some in-depth interviews with the researchers with nutrition and non-nutrition backgrounds. We conducted and also the data collectors who were using these apps. And then we also did some semi-structured interviews with the study participants. For this method, for this qualitative study, we used unified theory of acceptance and use of technology model that is called UTAT for the in-depth interviews, which covers performance expectancy, effort expectancy, social influence, and facilitating conditions. So for the results of the objective 1, so we completed our food atlas that has food items including recipes, fruits, ready-to-eat food items from the market, including biscuits, soft drinks, and 3 portions of each food item is included in this food atlas. For food composition table, we had total ingredients of 719. Some are ingredient recipes, some are ready-to-use items, but in total, the generic recipes that were created are 319. So the result of the objective 2, so in the demographic distribution for the validation study, we had the mean age of the participants was 38. Most were females with secondary education, they were married and were housewives. So here's the result of the mean daily intake difference in the nutrients and the correlation between the two methods. So for the conventional methods and the food EAP, the mean intake was almost the same. For the Pearson correlation shows that we have high correlation in total energy, protein, lipids, calcium, and iron. And we also had high interclass correlation, all the nutrients. We also measured the measure of agreement through bulk almond graphs. And this shows the x-axis is the mean of the two measurements, whereas the y-axis shows the difference between the two measures. I just showed the energy, protein, lipids, and carbohydrates here, but all the plot shows narrow limits of agreement, as 95% of the points lies between plus minus 1.96 standard deviation of the means difference in all the nutrients. So the result of the third objective was the qualitative one. From the interviews from the researchers showed that in performance expectancy, they said that it is very convenient and useful tool. For effort expectancy, the automated feature of calculating the nutrients was well appreciated, and this shows that facilitating condition this can facilitate for dietary data collection. Interviews from data collector gave us the idea that it is less work in this app as compared to the manual one. And the semi-structured interviews from the validation study participant, they shows that this was quick and time saving when we collect data from food app.
All right.
So here's the
Unfortunately, Amber, we might have to shorten the presentation because the time's up
all
at
right,
the
it's
moment.
just the 2 slides left. Okay. So the outcome from dietary recall, 24 dietary recall, food app showed high and moderate correlation.
You have 30 seconds to wrap up with your final message, so just go to your last slide.
This
kindly.
is the implication, is the final message. Food app data collection less resource intense, and can be used to use in the big surveys. And now food app is being updated for self-reporting diet clinical use. Thank you very much.
Perfect. Thank you. We're quickly going to dive into a Q&A kind of period. We have about 10 minutes, a little less. Maybe we can catch up some time. Can I also invite all the presenters, both oral and virtual, at least the oral ones, to take your seat on stage? And if you've got questions, let's start rolling really quickly to make the most of the time. Please, would love to have presenters up on stage. Okay, perfect. We have a question right at the back. Maybe till we get a mic to you, in the interest of time, can you maybe speak? Yeah, okay. So question for Khadija, and you'll be number 2, okay? All right, great. Okay, perfect. Yeah, and you'll be 3. Great.
So Khadija, your outcome is supplement use, right? So I'm assuming that's self-reported data at the follow-up. So I'm wondering if that introduces some kind of bias. Also, I was wondering why you did not do biomarker testing, because supplement use might increase, but it might not be meaningful enough to actually counteract the deficiency. It's just those.
Thank you. Yeah. Khadija, would you want to quickly answer that? Oh, sorry. Yeah. Sorry, the person who just asked a question, can we just have your name and your institution? No, just shout it out. We can hear you. Okay. All right. Perfect. Over to you. Yeah. Sorry. We'll pause it. We'll let her answer.
Okay, so it was a very good question, and we did come up with the biochemical assessment of folate, iron, calcium, and vitamin D, but that was on a subset, not on the whole sample, given the limited funds. So we did not find any improvement in biochemical assessments, but what we found was, which I haven't presented here, given the time limitation. So there was no improvement in biochemical assessment findings, but the control group had more deficiencies compared to the intervention group at the end line. So there were no improvement, but more deficiencies in the control group.
Thank you. Your name, institution, and you can ask your question.
Myself, Abhishek Kumar. I'm working with PATH as a nutrition specialist, and I oversee the food fortification program. So my question is to Dr. Patil, that how you see that the proactive actions from the family actually helps these NGO and frontline workers in addressing these problems, particularly related to the apps while using and giving solution to the families. Yeah.
Right. Thank you. Please go ahead. Yeah.
Okay. No, thanks. I could not cover that because the time was quite short. So the way we implement it is, or envisioned it is, that when we enroll the family into the program, we train them on using the application. So they use their mobile phones and the application to register themselves and their children. It's very easy process. But we also then add the related frontline worker and the NGO worker into the list, so that whenever she detects, she also gets a timely reminder for the anthropometric assessment using just MUAC tape and visible signs of wasting, because we know that they won't be able to weigh the child or get the height measured. So based on if the child is yellow or red category, then the message also goes to the frontline worker and NGO worker. And that's how then they visit to verify whether the child was really potentially malnourished. So that's how we close the loop. Thank you.
Thank you. Next question, please.
Hi, I'm Dr. Afsana Habib from Lanka International, Bangladesh. My question to Khadija, that you have a, do you provided the app from your projects? And the next question is, what is the possibility of scaling up this M-Health in the rural area of Pakistan or any Asian countries, because your inclusion criteria is more focused on well-educated, like wealthy, urban focus. So this is my question. Thank you.
Okay, so we developed this application specifically for our research project, and it went through a rigorous testing and development process. And the other question, since this cannot be scaled up right now, because this is the reason we perform the efficacy study, not the effectiveness. So in order to test that whether digital health intervention can work in our population or not, because a very limited studies are present in Pakistan that has assessed digital health innovation in terms of increasing the routine immunization or increasing the polio vaccine uptake, but none of such like wholesome applications are present in our context, which has like aimed at improving the dietary or supplement use among pregnant women. So this was our first step to assess the efficacy, and we do plan to do the scale up and like effectiveness studies. Thank you.
Thank you.
I'm Nilufar Safdar from Karachi, Pakistan, Dow University of Health Sciences. Khatija, I think two of our colleagues already covered the questions. The first one was of the biomarkers, but I was also extending to that question, did you do registration, because these women were mostly from a well-to-do families, educated families. So did you do the pre and the post hemoglobin or whatever the biomarkers did you use? Was it done pre and post? And what was the post duration of that?
Okay, so the study duration was of 24 weeks. So at the time of enrollment, when these women were in the first trimester, we conducted the test in the first trimester. And then at the end of the trimester, which is 24 weeks, they were in the third trimester.
But you could still measure them because they were registered at the AKU?
Yes, we did
at the end of the pregnancy or something like that?
Yes, so the third trimester, the 24th week follow-up was towards the end of the third trimester. So we compared the pre and post, but that was only possible for a subset of women, but because not all obstetricians provide prescription for all biochemical markers. So hemoglobin data was available for many women, but not for folate, iron, calcium, and vitamin D.
So intervention group did see a change?
There were the deficiencies stayed same. In the non-intervention group, the deficiencies increased.
So
Thank you. And we have to now move to the next question.
Deficiency, what do you measure deficiency for?
So we perform the serum level assessments, and then we categorize into normal and abnormal levels.
Okay, thank you.
Okay, perfect.
Good afternoon. My name is Arpit, and I'm from International Center for Research for Women's. And my question is to Dr. Pawan. So did you look into the peer influence for the mothers? because as the peers, they influence mothers a lot in their decision making. So, and if they have made any kind of influence, so how you have tackled that misinformation or misconception and into your program or your intervention? Yeah.
Thanks, Arpit. Yes, the app was designed with multiple focus group discussions, and while sitting with the community, even the logo that was, we kept on asking, oh, this is how you want it to be represented. What should be the name? All of these things have come from the community while being with them, but. It is very important what the others are doing, right? And that influences. That's why the first training of the application, its use, though it's very simple, it's like almost 3 minutes of the training, but it can be, it is done in a group setting where all the other women with the children of this particular age group, they are trained together. So they are told about the app together, and then they are also asked feedback about the use together. So yes, that's very important aspect of not only the designing of the app, but also implementation of the app.
All right, we'll have the last question now.
Perfect. This is Samarth Kashyap, and I'm from DSTC. My question is to the second presenter, sir. You mentioned usage of blockchain. Now that piqued my interest, considering I'm co-founder of a digital innovation company. Can you please elaborate on how that affected your system and a little bit more on the need for blockchain? Thank you.
Yeah, usually when we transact energy among us, utilities participate. And utilities end up putting in two kinds of difficulties. One is the technical, the other one is financial. So technical difficulties, I believe most of us who are associated with the utilities and energy systems is quite clear about it, because the blocks in which energy is traded is usually 15 minutes duration. Okay, so we are trying to bring it down to 5 minutes, but still like it's in the works, it's not yet happened. So that is a major difficulty. The other one is financial, because the utilities, they themselves are, I would say, it's probably a legacy problem, because they themselves are not very efficient, and they are very slow moving, most of the utilities, I'll not say all, probably nearly all. So what happens is they end up putting huge amount of financial transaction charge. Okay, so our margin itself is not very high. So once you put that transaction charge and account for that, then the entire system again become economically unviable. Okay, so this blockchain is properly designed, because everywhere the trust that is required from the system is not same. So based on a particular situation, if the trust requirement is not very high, in most of the cases it is not very high. So in that case, we can actually make this entire system so lean that the transaction charge can be avoided, and yet the technical requirements are not very not very prohibitive. So it's quite modest.
All right, with that, sorry, we're just going to wrap up the Q&A. Ladies and gentlemen, quick round of applause for our first presenters. And we now move on to a rapid fire round. So very quick introduction. Each speaker gets 2 minutes. So when you come up here, please don't introduce yourself. Your details are there in the booklet. And we'd really like you to dive straight into the core kind of messaging that you want to communicate, because you only have 2 minutes to do that. Once again, thanks for the presenters. I'd like to invite up onto the podium our first rapid fire speaker, Nilmini Karunaratna, who will be speaking around acceptability, likability, and usability of smart devices to track and improve food choices among adolescent girls. Thank you. Nilmini, over to you.
Good evening, everyone. Imagine an adolescent girl scrolling through her smartphone, maybe chatting with her friends or playing a video. Now imagine that same smartphone becoming a tool that help her to improve their food choices. So this idea sparked our study. So because adolescence is a critical period of growth and their food choices are shaping their future. Yet we are faced the triple burden of malnutrition among this age group. To address this, we developed an innovative AI-based smartphone application called Franny. I assure most of you now heard about Franny. So Franny recognizes food images and analyze nutrient contents and provide personalized nudges to improve their food choices. But we had to ask, would this approach is practical and acceptable for Sri Lankan adolescent girls? So we conducted focus group discussions using a qualitative approach, and the qualitative data was analyzed under key major 3 themes: acceptability, likability, and usability. According to the research, the girls here found the concept of using smartphones for meal planning and dietary guidance. However, there are some challenges such as shared smartphone with their parents and concerns of academic distractions. And usability insights emphasize the special smartphone app features like gamification. So in conclusion, smart devices for dietary assessment among Sri Lankan adolescent girls found to be acceptable, likable, and usable. However, shared smartphones with their parents was a major challenge. Also, the study highlights the potentials of leveraging technology to address the nutrition challenges among this age group. Thank you.
Thank you so much, Nilmini. Next, we have Raj Nandal Mandal. He is the Senior Project Manager from Helen Keller International. And 2 minutes to you to talk about enhancing health systems through digital innovations in Nepal. Over to you.
Thank you. So, good afternoon, everyone. I am honored to share with you the remarkable journey and the achievements of Transforming Lives Through Nutrition project, funded by Latter Day Saint the Church and implemented by Helen Keller International in Nepal. So, the project in the leadership of Nepal government showed some of the digital innovations to tackle the existing problem in the Nepal. So, talking about the background, it has been 15 years since the implementation of the IMM program in Nepal, but still we face the challenges of poor coverage, poor counseling, and inadequate access to services, those type of things. So, to combat these challenges, the project introduced like QR code and DHIS2 system in the current existing IMM program in the Nepal. So, QR code, while after the screening of the children, once they, based on their assessment results, like we provided green, yellow, and red card to the children with QR code, and those QR codes was integrated into the DHIS2 system. So based on that, our community mobilizers just track all the children throughout the treatment journey and also track the stock of the Super Cereal Plus. So talking about the findings, we are successfully screened more than 63,000 children. Among them, a little about 4,000 were found MAM children. And an impressive result of 95% of cure rate we achieved, with only 2.3% of default rate, and no deaths were reported. So this exceeded the like sphere standard rate. So QR code and DHIS2 were found crucial in tracking the cases from follow-ups, referral to like recovery of the children. So talking about the significance, the finding of this project clearly demonstrate the potential of digitalization to enhance and optimize the health system. Thank you.
Thank you. And next we have Ravihari Jayasekara from the University of Peradeniya, who will be speaking on the role of AI and digital technology in enhancing nutritional health in Sri Lanka.
Hello everyone. My research focuses on leveraging artificial intelligence and digital technologies to enhance the nutritional outcomes in Sri Lanka. So I gathered relevant literature from Google Scholar and I Explore. Out of initially identified 166 articles, only 40 were included in the final analysis after the screening. Because the exclusion criteria was the not peer-reviewed articles published before 2011, and then if we talk about the findings, my findings were outlined into 3 main categories: smartphone applications, then telehealth interventions, and artificial intelligence. If I talk about the smartphone applications, smartphone penetration in Sri Lanka is 47% according to the previous literature. Various applications were developed for different purposes. For an example, Smart Glucose Manager for diabetic management and My Smart Diet app for menu planning. In addition, various applications like DietShoe and HemoSmart extend mobile functionality by extend with another device. If you talk about telehealth interventions, mostly after the COVID-19 pandemic, they became more popular and handy. They offer transformative solutions like e-consultation in remote areas, e-learning platforms for healthcare professionals, and maternal services. Finally, if we talk about the artificial intelligence or AI, it is the latest technological advancements that promises personalized menu planning, improved risk predictions, and enhanced public health campaigns. So, in conclusion, I would say AI and artificial intelligence, AI and digital technologies enhance and are reshaping the healthcare access and nutritional outcomes in Sri Lanka. Thank you very much for listening.
Thank you very much for staying within the 2 minutes limit. Now we move on to the virtual presentation. We now have Roshan Chandras Mende, the program officer from PATH, and he'll be talking about strengthening neonatal healthcare systems in underserved areas. So Roshan, 2 minutes to you.
Hello, everyone. Am I audible? Can you please confirm someone?
Yes, we can hear you.
Yeah. So thank you. Good afternoon, everyone. I'm Dr. Roshan Mende, Program Officer from PATH, India. Thank you, organizers, for giving me a chance to present. And I'm really happy to share my experience on improving the feeding practices for the infants in the remote tribal region using the telemedicine as a platform. We are implementing this program by collaboration with the Department of All India Institute of Medical Sciences, that is AIIMS Nagpur, and the Public Health Department of Maharashtra at the Dhani SNCU. SNCU stands for the Special Newborn Care Unit. Geographically, Dhani is a very hard to reach part of a Melghat region. The region's institutional birth rate is only 44%, and it's very well known for its highest infant mortality rate, maternal mortality rate, NMR in Maharashtra and in India. Even in the findings, you can see that in the gap findings, when we done that assessment, we found that irrational use of the antibiotic and the IV fluids and the lack of KMC and the early restriction of breastfeeding practices. So we established PATH supported to establish the telemedicine services by hub and spoke model of and where the teleconsultation actually started. Our focus not only on a teleconsultation but also on the improving the skills of the nursing staff related to the feeding practices and the strengthening the thereby strengthening the lactation management practices. And the first achievement that was like to reduction in the newborn admission from the PNC wards to the SNCU. So that actually motivated the nursing staff. Then after that, we further implemented the training modules on the facility-based newborn care, and the results are really encouraging. And you can see in the chart that the newborn death rate actually reduced by nearly by 50%. Then the referral rate reduced by 15%. The sepsis rate goes down from 21% to 6.3%. The antibiotic use reduced by 65.8% to 36.8%, and the RDS respiratory distress syndrome rate actually decreased from 41.4% to 22.9%. So for conclusion, telemedicine can bridge the gap between the urban and the rural part, where the scarcity of resources is there, and unavailability of the skilled personnel. And this can be a potential solution to improve the newborn outcome, and through which we can achieve the universal health coverage and the sustainable development goals.
Thank you. Thank you very much. And we next have Stella from the Global Alliance for Improved Nutrition, speaking about a use case in Bangladesh about using an AI chatbot to help users explore and understand food policies. Stella, 2 minutes, and over to you.
Improved nutrition requires having supportive policies. And getting those supportive policies is more likely if civil society, researchers, and ordinary citizens can advocate for policy change. The first step towards doing this is understanding what those policies say in the first place. But this is difficult. Food system policies span many sectors. They can be hard to track down. They're often long, technical documents full of jargon. In short, many of us end up overwhelmed and not knowing where to begin, like the woman on the left. Chatbots based on AI-powered large language models could help solve this problem. They enable users to ask plain language questions and get plain language answers back. But those that are publicly available online, like ChatGPT, can draw on unreliable sources and even make stuff up. So we decided to see if we could make a custom chatbot that would answer users' questions drawing directly on the contents of policy documents. And we applied it to Bangladesh as a proof of concept. The steps involved identifying food policy documents from Bangladesh, processing them to be a database understandable to the chatbot, and testing to ensure high performance. The resulting chatbot can take user queries, retrieve relevant text from the database, and generate responses based on it. For example, a user could ask, what are the key strategies for improving food safety in Bangladesh? And the chatbot will identify the relevant policy and summarize the key strategies in it, such as strengthening certification agencies and engaging in consumer education. All testers agreed the chatbot had a high level of accuracy, provided clear responses, and was easy to use, suggesting it largely met the goal of making policies more accessible, like the happy woman on the right. But limitations arose in comparing across policies and providing responses that considered all policies comprehensively, which limits the applications in research. Overall, however, the chatbot offers an easy, accurate way to talk directly with food policies and learn more about them in the process. Thank you.
Thank you so much. With that, the rapid fire session comes to a close. Once again, a big round of applause to our presenters. And we'd like to take this opportunity to thank everyone for joining us. Now, before I close this session, just a gentle reminder as we see a lot of benefits as we transition towards digital innovations, but please be mindful of the trade-offs that come with it. We've heard also from the various speakers that digital penetration is still a very big limitation. And if you have seen other sessions, sometimes the connection, just getting connected is a big problem. So probably as we transition, think about a hybrid model before you move into a full digital transformation. Mivan?
Yeah, likewise. I think the theme "Tech for Good" is catching a lot of traction from around the world, and that's something that we have to be all mindful of. Just as some was mentioned in my introduction, I work with about 700 startups, and a lot of these startups are in the space of tech for good, whether it's solving different problems in different industries. And particularly at the moment, we're designing and implementing Sri Lanka's National Agri-Tech Accelerator. And there again, we're seeing a lot of kind of technologies that can vastly change livelihoods for smallholder farmers, but also impact food supply chains as well as the overall health and nutrition aspect of Sri Lanka. So really, really interesting stuff today by all the speakers. So thank you very much. Thank you to all also the audience and those who submitted questions. I don't want to take too much time. Let's wrap up just in time for a quick tea break and continue the rest of it. Julie, over to you.
All right, thank you very much. And please join me in thanking our session chairs who did. It was a very formidable job, but I think you did very well, so thank you very much. Thank you to all of our presenters. Our next session is starting at 3 o'clock sharp. And then in this room, we have methods for estimating beneficiary populations. And that's a learning lab by IFPRI, but we also have 2 other learning labs as well. So thank you again for your attention, and please join us for some tea.